Okay, I think, thank you very much. I think we must move on. Thank you very much indeed. Mr. Pagano from Birmingham is going to tell us how myocardial viability affects survival. Tom.
Thank you very much. Can I have a first slide, please?
Maybe start by defining what viability means, because there is a lot of questions around that.
We will. We hope we will. Okay. So you heard before at the beginning of the session from Professor Pepper that really the issue of viability needs to be applied to patients with heart failure because most of the studies that have been done where viability has been looked at and see whether it could be indicated as a prognostic indicator is actually been done on patients who already met conventional criteria for coronary artery revascularization. A few things before I start the talk. First of all, I'm not going to talk about any issues regarding the mitral valve in ischemic cardiomyopathy here. I'm merely going to show you the data or the lack of data with their limitations in this group of patients. Historically, from the randomized trials, we knew we have the data to inform decision making for chronic ischemic heart disease. If you had angina and you had ejection fraction more than 35%, you get the answers from the old randomized trials. If you had angina and you had an ejection fraction less than 35%, you get your answer from the registry trials. And with regards to heart failure, there was no randomization. These are trials in the early 80s. And I'm afraid we are still at the same, in the same position, as Professor Pepper quite rightly mentioned. And therefore, the level of evidence for revascularization purely for heart failure is very poor. So there is a lot of selection bias. The issue of viability is really because some time ago it became apparent that chronic post-ischemic left ventricular dysfunction was not always an irreversible phenomenon. And the presence of cellular viability in dysfunctional segments predicts recovery of function if revascularization is done to those segments. So the question is, if you got myocardium that is not working, is he really asleep or is completely dead? And that's how the question, the title of hibernating myocardium was created. It's really recoverable left ventricular dysfunction, so you can only find out after you've done the procedure. That's not very useful to us. It can be predicted by the presence of cellular viability and is due usually to a reduced coronary vasodilatory reserve, and that's why by doing revascularization you improve it. So, you heard Professor Pomar at the beginning saying, let's just define what viability is. If you really have here a segment of myocardium which is dysfunctional and is subtended by a stenotic coronary artery, you've got in this segment a mix of things. You've got scar tissue, and you've got some degree of viable myocardium which is dysfunctional. Now you've got different tests to test for different things. Now the MRI gadolinium enhancement will actually show you where the scar is, and Professor Menicanti showed us earlier this is very important for you to understand where you want to take some myocardium away. But a number of other tests here are used to test whether you've got cellular viability. And the three most important commonly used methods to assess cellular viability, not scar, are either tests that show inotropic contractile reserve, and typically it's dobutamine echocardiography. You can have dobutamine MRI, which is really, really good, but very difficult to do. You can look at sarcolemma integrity, where to look at cells that are viable with thallium scintigraphy, and you can look at the presence and persistence of metabolic activity with positron emission tomography, usually with a glucose analog for the deoxyglucose. So let's go back to the clinical questions. If we take patients who come to us with left ventricular dysfunction, severe left ventricular dysfunction, how commonly do we find viability in those ventricles? Well, this is a list of some of the studies. These are again single series from 1999 or in the early 90s. These are the number of patients and the mean ejection fraction. And you can see that if you look at the percentage of patients with viability, quite encouragingly you find some viability present in at least 50% of these patients. So it's quite prevalent. So the next question is, what is the impact of viability on patients with impaired left ventricular function? So what happens if you got viability, you got impaired ventricular function, and you take tablets? Well, this is one of the studies published in '94. Here you've got four eventualities. You've got patients who are revascularized or medical treatment who haven't had, who either have viability, or no viability, and this is the incidence of ischemic event. And you can see that at least on this endpoint, there is no difference in outcome if you treat them by revascularization or by tablets. If you then look at the viable group, these are patients with viable myocardium. FTG stands for fluorodeoxyglucose. That means these patients were tested with positron emission tomography. If you treat on medical treatment, these patients who got a lot of viable myocardium, it looks like they've got a high incidence of ischemic event during the time course, whilst if you revascularize them, the ischemic events are less. If you want to predict cardiac death, these are the univariate analyses, the Kaplan-Meier survival curves, or patients who are dobutamine negative, that means they're not viable, and these are patients who are actually viable. And you can see that if you treat them medically, the patients who are viable do worse than the patients there. So far, it looks like that the presence of viability, would you like to answer your phone? The presence of viability may be associated with an increased risk of ischemic events and thereby adversely affect prognosis. And can revascularization of viable myocardium improve outcomes normally associated with prognostic benefit? So let's look just at the endpoints that we normally associate with prognostic improvement. This is some of the work we did in Birmingham some time ago, and you can see here that whether you test with positron emission tomography or with dobutamine echocardiography, there is a linear relationship between the improvements in left ventricular function following surgery and the number of viable segments that you have preoperatively. And it's quite intuitive to see that the more of the viable myocardium you've got, the more is your improvement in ejection fraction. So how many segments do you actually need to improve left ventricular ejection fraction for at least 5 percentage point? Well, if you use positron emission tomography, you need to have 8 out of 16, so 50% of the myocardium. If you use dobutamine echocardiography, you need at least 7. So you need at least 50% of the myocardium, at least in our series. And our series had really patients with severe heart failure and a mean ejection fraction of 30%. If you just cumulatively look at other studies, again here you've got your delta ejection fraction change after surgery of at least 5 points, and here you've got the percentage of the left ventricle that is viable before surgery. You can see that most of the improvement occurs when you got at least 20% of myocardium being viable. What happens to peak VO2, which is a very strong prognostic indicator in patients with heart failure? You can't do this if patients have got angina, because of course they're going to improve their peak VO2 because you relieve the angina by doing revascularization. This is in a group of patients who had predominant heart failure symptoms, and they go from 15 mils per kilogram per minute to 22 following surgery. So these were viable patients with a lot of viable myocardium. You can predict the improvements in heart failure symptoms, again according to viable myocardium. These are the improvements, and there is the percentage improvement from baseline seems to be linearly correlated with the percentage of left ventricle that was viable before surgery. So, revascularization of viable myocardium appears to reduce ischemia, improving cardiovascular coronary vasculatory reserve. It improves contractile function, is proportional to viability index, improves clinical status, improves objectively measured exercise capacity, but can it really improve survival? Well, according to some of these, again, series, it would appear to do so. What you have here is what happens in patients that have been treated, they are viable, they have been treated either surgically or medically. So this is viable myocardium treated medically, this is viable myocardium treated surgically, and here you've got no viable myocardium, no much difference whether you treat them medically or surgically. There seem to be also, this is another study, but it's important for another reason, a small number of patients again, but you can see the difference on survival of medical versus surgical treatment, where surgical treatment seems to be better than the medical treatment. And if you really want to look at a meta-analysis of non-randomized observational studies, you have here a total of 3,000 patients. You've got non-viable patients here treated with coronary artery grafting or without, with medical treatment. Same results on mortality rate at 18 months, but the only advantage you have is if you got viable myocardium and you get treated with coronary revascularization compared that if you're left with medical treatment. So your mortality rate is high in this group who is viable. Let's look what happens to ejection fraction. The difference between surgery and the medical treatment in viable myocardium seems to be quite good when your ejection fraction is between 30 and 39%. If you go to the CAS registry equivalent, again, there seems to be an advantage. However, if you have very poor ejection fraction, there doesn't seem to appear that there is actually any difference whether you treat with coronary artery bypass grafting or medicine. And this is a small group of patients. The reason I actually show this is because to start the idea that actually if your ventricle is too bad, even if you got viable myocardium, it doesn't really look like you're going to improve your outcome. And this is one of the reasons why you don't improve your outcome, is because there is a relationship, an inverse relationship with your initial end systolic volume. The more dilated is the ventricle before you start, even if you are viable and you got a lot of viability, your chances of improving your ejection fraction is not very good. So, this is another complex slide, but in fact I'll try and make it easier for you. If you look at a number of, the viability per se is not the only indicator of prognosis. We know that diabetes and the number of vessels that are diseased is a strong prognostic indicator in the long term. Now this interesting study showed, first of all, in the group of diabetes and multivessel disease, these are the risks of death. You look at the medical treatment, the risk of death is greater than 16. When you revascularize and it's not viable, it still reduces the risk, and that's because probably you still got some prognostic benefit because of multivessel disease, and if you revascularize viable myocardium, then you have even a better improvement. So when you move towards here, your risk of death actually increases. This is your baseline risk. Now, of course, if you go to no diabetes, you start off in a better prognostic group, but you can still see the advantage. If you have no multivessel disease, one or two vessel disease, then you start losing the advantage of revascularization. But you would expect that because we know that the patients that do better are those with three vessel disease, with diabetes, and with viable myocardium. So, if revascularization can improve survival in ischemic heart failure patients with myocardial viability, how much viable myocardium is required to obtain those improvements? Well, quite a lot, and there is, and I'll put it to you that it depends on also how bad is your ventricle before you start. Again, this is looking at volume, and you can see that the prognosis really is strictly dependent on the amount of viable myocardium before. So if your viability index here is 0.67 and is about 50% of the ventricle, your survival is better if you get revascularized than if your preoperative viability is less than 50% of the myocardium. This is our work which really confirms this in a small group of patients, and you can see that really if you start with more than 8 viable segments, or at least 8 viable segments, your 48 month survival was 86%. If you had less than 8 viable segments, your survival was significantly lower. And again, this shows exactly the same thing. It's a different group saying that if you, before your coronary artery bypass grafting, if you have more than 5 viable segments, your survival is better than if you go less. This summarizes it again. This is your survival, percentage survival. This is the average survival in patients who are non-viable with similar ejection fractions and multivessel disease. And you can improve them if you got at least 20, but better if you got 35 to 50% of the ventricle which is viable. If survival is improved, this appears to be proportional to preoperative mass of viable myocardium. Does this survival really depend on improvement in left ventricular ejection fraction? Again, this is a provocative study, but it's important to focus the mind, and particularly in the context of what we heard before about ventricular function and dilatation for the stage trial. This is a small study of 135 patients with ejection fraction less than 30% who underwent coronary artery bypass grafting. There were 128 survivors from surgery, and there there was a pre- and postoperative measurement of ejection fraction. And the patients were divided into two groups. Those who increased to at least 5 percentage point the ejection fraction, called group A, and those where there was no difference in group B. Now, what do you expect the survival is going to be between these two groups? Well, you all expect to be different, but in fact it wasn't. So this is just to show that not always the improvement in left ventricular ejection fraction is the major determinant of outcome in these patients. But we don't have the answer, I think. I think this data has got a lot of limitations, so we need to keep that into account. All this data is derived from studies with relatively small number of patients. There are nearly all retrospective case series, and there is absolutely no randomization or control. There is always publication bias. Poor coronary artery bypass grafting results, particularly in this group of patients, and negative studies are not reported. Viability is never been used, or in very small series has been used to decide the treatment. The treatment was first decided on conventional clinical criteria, and then the viability test was applied. There are almost no series in which revascularization for heart failure has been solely examined. There is a varying and large fraction of patients with angina who would have undergone surgery at least for relief of symptoms in this series, regardless of the amount of viability they had. We heard before about the need of doing randomized trials. We also heard about the limitations of potential randomized trials. I'm going to show a classical example that where surgery is a high risk, why a randomized trial can actually give you the result of the answer that you want. Now, what better issue than patients with cardiac shock? Now, in the 80s, we had the dilemma whether to treat patients with cardiac shock with emergency revascularization. Clearly now that's not the case because of primary angioplasty and so on. But at that time, people looked at the results of the Gusto-1 registry, and they looked at about 3,000 patients. And they looked at the difference of these patients. This is non-randomized, okay? This is the registry. And what happened is that the non-intervention group had a mortality of 55%, while if you intervened on patients, you had a coverage mortality of almost 30% and an angioplasty mortality of 22%. Well, a huge difference. Then it would, just looking at this series, you will say, of course, intervention has got to be the treatment forward. You almost half the mortality here. So what do? They actually designed two trials, the shock trial and the trial done in Switzerland. And as soon as you take, what happens here, before I go to the next slide, is that the surgeon goes at the end of the bed and selects the patient. There is selection bias here. Now you select the patients, and that selection bias is important. When you don't select anymore, you just randomize, this is what happens. You now randomize these patients, and your medical and surgical mortality is the same in two different trials. And that's why a randomized trial could be very useful to you. Thank you.
We have time for one or two very quick questions.
Lorenzo.
Yeah, very quick question. Bax recently published a very interesting paper in which he showed that if you have viable myocardium and you revascularize that, you have no benefit if the ventricle is really big. Yeah. And Gast also showed clearly that the volume is the major factors that influence mortality at 1 year. So ejection fraction can be useful if there is a globally equal akinesia or low for contractility. Is